Oh. This is just for Steve Bloom. I don't know if you guys know about Retina Rocks, but this dude, as an individual, has made an online database for Retina so good that it's better than all the academic centers in England, Harvard, on the coast, everywhere. Ask Palmer. Retina Rocks is actually the online video image database for the World Retina Congress. www.retinarocks.com. It's amazing. So our guy is just obsessive, man, and he's really, really done a good job. They have reviews of all the best articles summarized for you. They can push to your Instagram. There's cases of the month. It's really, really something that he got all that going as an individual. And here's a sad story. Well, that's the Instagram. That's not the sad part. So you can get on Instagram too. But this guy, he used to hate the retina, and he was really unpopular. Then he signed up for Retina Rocks. Now he loves the retina. He's got lots of friends. So, anyway, that's for you, Steve Bloom. Steve really, really worked his butt off. Interesting. Racquetball record, 0 out of 7 wins. 7 out of 7.
We got to update this slide there, Kevin.
I don't think we need to update anything, and I think that's what's this? Put that slide in there. Tennis record. People don't care about tennis, Ian. Oh my God.
It's all about pickleball now.
I don't know. Post-op care, we're going to show you from the touchy. Whoa! What the heck is that called? That's touchy with a 3-piece lens and a capsule opening. That other guy must be... Oh, no. So, we're going to show you a few interesting things. Okay, so post-op. We're going to review all these things. And usually we'll send post-op forms if a patient's or if a practice is doing co-management. First 3 days, you check vision, pressure, slit lamp, and that all should improve each visit. The way it appears, their vision. At the 1 or 2 week, that's when you want to dilate. If they're custom, they better get a refraction, basically to show are we hitting our target. And the reason is we might use our data to cheat. Like a sniper, if you fire the first bullet and they have a tendency to drift myopic, you're going to cheat hyperopic on the second. And then at the 4 week, 6 week, you check again. Make sure you're not getting rebound inflammation at that point. And rebound's more subtle with Trimoxy. With drops, I was taking drops, stopped them, then I got rebound the next day or two, and it's like boom. With Trimoxy, the medicine's going away very slowly, and then very slowly I got inflamed. It's not like a boom. So just be mindful that some redness or anterior chamber cell could be rebound inflammation.
And honestly, I find that, just to prevent callbacks, if they're at the 1 week and they have a little more cell than you expect, it's way easier to just put them on a steroid while they're in the office and make them happy than wait for them to call you back in 3 weeks and get working your schedule saying their eye red and inflamed. An ounce of prevention's worth a pound of cure.
Absolutely. And yeah, no doubt. How long do people usually wait to prescribe glasses after cataract surgery? Is it like a month? Is it 2 weeks?
Yeah, 3 or 4 weeks.
3 or 4, okay. We already talked a lot about Trimoxy and drops. If you're doing drops, usually we'll take antibiotic drops every hour the first day, just prevent the infection. And then steroids tapered 4-3-2-1 over a month, and NSAID, it kind of depends on the type. Some are once a day, they'll charge like $350 for a once-a-day NSAID, which is the least important drop, or you could get a generic 4321 for like $40. So you can already guess what I think about that.
And a lot of companies now, or a lot of practices won't do necessarily the no drop Trimoxy. They'll do less drops, and they'll put all those medications in one bottle, and then you taper it down. Only issue with that is you're tapering an antibiotic, so you are exposing bacteria to, a constant antibiotic that eventually will selectively mutate, and then you will develop.
That's a really good point. Yeah, tapering, combo drops. If it gets worse instead of better, more inflamed or more pain, even if you don't see a lot of cell, you might want to increase the anti-inflammatories. Because everything should get better each day. Call us if it worsens. That's the main thing. All of these. So with pain, usually you feel the incisions. It's foreign body and burning sensation. Some people don't feel it, but at least half of them do. When that lid comes across that little paper cut, some people are more likely to feel it. 90% is better the next day, substantially, 90% of the pain. But just remember, if they have dry eye is another cause of surface pain. So if you have two causes of surface pain, you're going to have worse surface pain. Especially the patients who are like subclinical dry eye with just a little bit of symptoms. Oh, now it's bad. It's not your dry eye worsening, it's just additive irritation. Pain lasts longer if you have like an epithelial erosion. Be mindful of brow ache and nausea. Is that signs of high pressure? But always evaluate worsening pain. Maybe it's endophthalmitis or something.
And notice the choice word that Dr. Chamberlain used there, epithelial erosion. Definitely how you present that to the patient there. It's not that the surgeon scratched your eye or clawed your eye out. They had a little erosion after.
Absolutely. Yeah, we're going to actually in this review some of the key conversation points, and then a lot of this is about communication with the surgical team, because it'll guide us on the second eye based on your findings. But they're usually pretty blurry at the start, but by one day, with gentle surgery, most people are seeing better, unless the Trimoxy's taken a while. But like we said, always see them if the vision's worse, because who knows what it is. Floaters, you're always going to have it with Trimoxy. 100% of the time, it moves up over time. So much of it's better in the first 2 days. Every now and then, you get dispersive Trimoxy, where it's just goes into like a complete milky fog, and then they're like hand motion. But I think it's the quality of some people's vitreous that makes it do that. But remember, floaters get better each day, not worse. If they suddenly have a new shower of floaters, how do you know they don't have other causes of floaters like a vitreous hemorrhage, retinal bleed, retinal tear, detachment starting? So you always got to see it if it worsens. So pretty consistent message. If they get a PVD, now you got one to last. Sometimes they get them after a cataract surgery. Like, surgeon caused this. And they don't say, yes, he did. He caused it. A better way of discussing this is 80% of us are going to get PVDs throughout life. It's just part of the natural biology. Think of a PVD as a leaf that may fall from a tree. The cataract surgery, or just rolling over in bed, is like the wind that rustles the branches that might make it more likely to come now. But more likely that's the next card in the deck for you. And it's just being turned over now. It's your biology. We didn't give this to you. But there's actually been people trying to make lawsuits over PVDs. It's interesting patients. More just a tragedy of poor communication. Because if you communicate right, basically saying you have no legs to stand on, that's ridiculous. You shouldn't sue someone because you have a PVD. Epithelial defects. You've got a scratch on your eye. Oh my God, look at that from top to bottom. What, did they take a steel wool applicator and just grind away? And then they get edema in the cornea because maybe it's inflammatory, but more so it's osmotic. It's letting the tears hydrate the cornea. We'll talk about that later. But if they're not hypertonic, tears will rush in because the barrier is down. The cornea likes to have an intact barrier front and back. So it gets really edematous. Maybe you should say you have abrasion. Don't say a scratch. I don't want it to sound like I took a steel wool to the eye. That's kind of mean. Don't say either one of those. You have an epithelial defect. Most likely a spontaneous erosion. Most erosions happen in the absence of surgery. You get a little sticky, your layer is loose enough that it separates in the morning. And then what if you had pre-op drops, surgical exposure, lots of post-op drops? That might, or post-op rubbing too, don't forget about that. A lot of that might irritate your epithelium enough to make it want to be devitalized and shed earlier. So, and just remember, don't just think it all happened during surgery. If it happens during surgery, it is easy to see, and we are going to treat it. We'll just place a contact. Here's an example. There's a patient in surgery. Look at that in the middle. When they put the lead speculum in, can you miss that? It's obvious. Before we moisten the eye with viscoelastic, you can really see. So, here we're doing a PI closure. Jump through that surgery. And I'm just going to lay that bad boy down, put on a contact. So if we saw it, or it was caused during surgery, this is how they arrived to your clinic with a phone call saying, hey, there's a contact we want to remove in a few days. So the treatment for an epi defect, put on a contact, but you better put an antibiotic on too. If they're on trimoxy and they're going to have a contact for an extended period of time, they better have antibiotic. Now, we give the subcons trimoxy day of. That will cover a contact for a day or two. But if you're going beyond that, take some antibiotic. You have to slide the contact to the side to tell if it's healed. If you just put the stain on the surface, a lot of it doesn't get enough to stain and color it. So trust me on this. Some epi is hard to see and it's less gray than others. And unless you slide it and let them blink, you won't be able to check it. So don't just say, oh, no stain, take it out, throw it away. Wait, put in the stain, slide it, blink. Now is it okay to take it away? And maybe leave it a few extra days if it looks like weak epithelium. But this comes back to the communication. Why do we need to know this, Ian? My little guy's not working.
Yeah, if they're prone to it, I can try to alter your course for the second eye.
Yes, we absolutely want to know. So if they got a spontaneous erosion on the first eye, I'm going to give them a contact on the second eye as a preventative measure. Because you got the same biology here as you do there. Erosions come down to amount of friction and amount of epithelial weakness of adherence. And if you've got genetic weakness of adherence on one side, you're going to be high risk for the other. So we do it as a preventative measure because erosions suck. They're very painful. Pressure spikes. So as we said earlier and hinted, it's a sedimentary process. It's the debris of surgery. Maybe some energy irritation can irritate meshwork cells just like it can irritate endothelial cells. Maybe we're not rinsing out all the viscoelastic, but you can't rinse all of it. Here's a big take-home point. Maybe a pressure spike is a sign of an unhealthy meshwork that can't even handle a little bit of debris. We know that if you have chronic debris in sedimentary glaucoma, you're more likely to get the spike. So in a person who's been just, hey, I'm normal range, my pressure is 18, 20, boom, I jump up to 42, maybe as your meshwork function goes down in life, you're actually going to be one of the patients that gets kind of low on function. And this is kind of like a tropicamide challenge test. How narrow are these angles? Is it enough to take the pressure up? Hey, let's dilate halfway for a little bit. Pressure doubled. Whoa, I guess you are occludable. Same thing. So especially if your surgeon normally doesn't have pressure spikes, so we hydrate the wounds well so they don't leak, but usually we get a lot of the stuff out. But if you're not used to seeing pressure spikes and you got one here, especially if it's on both eyes, you better label them a glaucoma suspect. So to burp or not to burp? Another discussion. Pressure is 66, Ian. Should we burp that?
That's an easy yes.
That's an easy yes. That's way too high. Absolutely. Pressure of 35. Ian, should we burp that?
I think you start getting into more of a nuanced conversation. I typically do. I think their pre-op top to disc ratio, their pre-op target is, and pre-op IOP is important there too. If they were ocular hypertension and their pre-op IOP is 27, then probably not. But if it's you need a pressure of 11 for an NTG patient I give there, then yeah, you definitely got to.
Yeah, if the more risky it is, the more likely you are to take it out. If they've demonstrated that they worsen with, slight raises in pressure, or the normal tension glaucoma, definitely burp that. They're monocular with a 9.9 cup. We can't tolerate any worsening. Burp it. So, and just remember that if they get microcystic edema, the kind of edema that you get from high pressure, you might underestimate a lot. I had one patient who had a horribly edematous cornea with an ulcer. Pseudomonas took months to go away. Always complaining of a brow ache. Always had a pressure of like 15 to 20. 9.9 cup when we were done. So it's like, wait a second. The squishy edematous cornea hit a raging glaucoma.
Yeah. I mean, I'd probably err on the side of caution with these and burp more than others. It takes longer. I mean, it makes the post-op take, a little bit longer. You got to document a little more. But if there's retained visco in there, I want to get it out, because the one thing I hate is when they come back at a 1 week visit and their pressure's still up. Ooh. And I know that they were probably higher than that 35. The tech measured it wrong or whatever.
Good point, Ian. Good point. Yeah, applanate. Don't just use the eye care.
Yeah, right. And so if it's up, I applanate, I check it, and then I'll just fix it then and make sure that they're 1 week they're down, because otherwise you're not sure at the 1 week now. Well, is this retained visco that there was a ton in there and you really measured it wrong, or are they going to have some crazy early steroid responder? Now you don't necessarily know exactly what you're dealing with.
Good point. So yeah, it definitely depends. So how do we do the burping? You got to numb them, betadine antibiotic, maybe a lid speculum. You don't have to, but you want to do this calmly. Just push on the sclera adjacent to the wound. It's under high pressure and it's been sealed for a day. It might not just flop open. You might have to push a little bit firm, but it's instantaneous. The fluid rushes out. Some people try to push on a small wound. I usually can't make those gape. It's too hard. But less risk of iris prolapse. As long as they're not dilated, the iris shouldn't prolapse. But then you're going to give pressure drops after you burp them down. It usually comes down real fast. And when should we follow up? 5 days? No. How do you know that the debris that took the pressure up isn't still in there to a high enough amount to take it right back up again? You're going to bring it back tomorrow. No. You're going to bring them back in 30 to 40 minutes, maybe an hour. Because if they're coming in at 66, you don't want them going home at 65 or whatever. You got to make sure it's down. And you're going to burp them as many times as it takes so that it doesn't rapidly rise in 30 to 40 minutes. So sometimes you do that. 66, 59, 42, 28. Okay, fine. Now you can go. But that's going to kind of tell you how many pressure drops do you need to go home on. And communication. Tell the surgeon. So this is a meshwork challenge test. If they had a big old spike on the first eye, maybe they're at high risk for that on the second eye. And I can give pressure drops. I can do extra rinsing. I can make sure to get a same-day pressure check. Like, you're not going home. You're going to the clinic in 2 hours. That's how we're going to treat the second eye. Just because it's the same biology. I don't want them going to 66 overnight, especially if they're monocular normal tension glaucoma or, something like that. Here's how you burp the eye. Here's the technique. Remember, it's a firm push. There's the side port. You could push that one. I think that one's a little harder to push. You got to really push, and then some comes out. Yeah, and you'll see that fluid rush out. But then I think on this video I show the other incision. Yeah, there comes a lot. Big old gush. The eye got soft. Now let's show you pushing on the large wound. Here's a large incision right there. Boom, it just gushed out. I'm going to back that up so you can see it again. Boom, it just shoots out. Just a split second. This is in the OR so I could get a good view of it. Here's another one. Big wound. Watch how easy. Go. Boom, boom, boom. I just barely touch. You got to push a little bit harder on the post-op day 1 because the wound's going to be sealed down a little bit. But that's. And
in clinic, I just use a sterile punctal dilator. A punctal dilator, coming in perpendicular to it is, so you're pressing basically right at the scleral margin where the incision is. Just gapes it open, and it just takes a second.
Now, corneal edema. It's typically only present near the wound for most cases because we're intentionally hydrating it to make it swell shut. As that edema spreads out, you'll see a few decimate folds near the wound. It's rarely going to be present centrally. And if they got prominent decimate folds, it's possible with dense cataracts, but usually that's concerning. Like, even as you saw in the case where we had the really, really dense cataract, if you keep coating the cornea, you're not going to kill all the cells. So you should notify the surgeon. And they can modify the technique for the second eye. Like maybe these are really sensitive cells. Maybe it's just inflammation. Maybe as soon as the inflammation goes away, they're going to have no edema with a normal cell count. But maybe it's endothelial damage, and I got to be careful. And maybe I can evaluate that second eye pre-op. Like before everything's like, you did this to me. It's like, wait, hold on, let me check your cell count on the other side. Dr. Bennett had a case like that, where, whoa, he needed the DMEC, it got so bad. We checked the other eye, the cell count was like 280. It's supposed to be 2,000 to 3,000. So the guy just had this, not Fuchs, but some sort of genetic problem with his endothelium. So we need to know that, and we can evaluate and plan a real gentle treatment. The etiology, of course, is maybe they got a low cell count, like that case from Dr. Bennett. Reduced endothelial function. Maybe it's temporary reduced function, and it's just going to go away when it stops being inflamed. Maybe it's genetically reduced function, like Fuchs, or just a low count, like we said. It could be not functioning because of all the energy exposure, but they're not quite dead. They're just irritated. And, but you got a dense cataract or a small chamber, you're going to have a lot more energy. The other thing is you got to wonder, is there some exposed stroma? So remember, if you have a rupture in Descemet's membrane, there's nothing to keep the aqueous out from hydrating stroma, and it balloons up. They call that hydrops. Same thing with an epidefect. Unless your tears are really hypertonic, osmotically they're going to rush into that cornea. So epidefect, DM defect, and there's an example of a DM defect. That's actually a DMEC patient, but on the bottom you can see a slightly separated DMEC. And it shows you that Descemet's doesn't just help pump out excess fluid. Descemet's endothelium prevents the influx of excess fluid. Because where it's not attached and you got bare stroma, boom. Someone left the front door open in the winter. It's getting cold in here. Same kind of deal. Of course, you can get high pressure causing edema, but that's usually of the MCE variety. Usually it won't have Descemet folds. Okay, inflammation, we talked about, 1+ cell and flares typical. It should resolve pretty quickly. You might see more if it's a uveitis patient or iris manipulation. Nail that into your head. Not unusual to see a rebound 3 to 5 weeks, whether it's drops or trimoxy. It's more gradual with trimoxy. You're going to give a steroid taper if you see it. But, be really wanting to do a slow taper, a long course of steroid, especially if you're seeing all this rebound inflammation on both eyes, because they're telling you there's something about me that's pro-inflammatory. Retained lens material is an underdiagnosed phenomenon that we did a lot of work on. Actually won a film festival for it. You can check the gonio and try to look in the sulcus, but to really look at the sulcus, we got to take an intraocular camera and go to the OR.
It was Sundance. He won the Sundance Film Festival, in case you were wondering.
ASCRS. So there's an example of one hiding in the sulcus, but if you watch Crouching Tiger, Hidden Fragment 1 or 2, you'll see some of the stuff we found.
And one note on this post-op stuff. So, let's say they have cataract surgery in both eyes. You see them. They have their second eye done, so you're seeing them for their 1-day post-op in the second eye and their 2-week post-op in the first eye. And the first eye, they're a little light sensitive. They got rare cell at the 2-week visit, but they're complaining of a little bit of light sensitivity. So you get some breakthrough inflammation on the 2-week eye, and you're going to put them on steroid 4 times a day for a week, 3 for a week, 2 for a week, 1 for a week. Automatically put them on the steroid for the second eye. Just going to help the second eye heal up and prevent the breakthrough in the second eye.
Yes.
They're already going to take it in one eye. No sense in waiting 2 weeks for the right eye to then break through, or the second eye to then break through. Just do it in both eyes and percent of a problem.
That's right. Pressure spikes. Second eye's getting acetazolamide in the same day pressure check. Bad inflammation. Second eye's getting trimoxy and topical steroid from the beginning, and we're going to taper it really slow. So inflammation, number hypopian, you gotta make sure it's not an infection, and we tap and inject and culture those, inject antibiotics. You can get CME from it. TAS is a steroid ophthalmitis that's like instantaneous. We think it's kind of like a hypersensitivity, but we're still going to treat it like an infection. The infections usually are 2 to 7 days, not 1 to 2. But if it's day 2, it could be anything. If you see vitreous inflammation, it increases the odds that it's infectious because bacteria just go straight back there and everything's inflamed. Where if it's an anterior chamber reaction, it's hypopian, but not necessarily vitreous cell. But still,
And
Here, go ahead.
yeah, so this is another point. We actually just had one of these unfortunately in our practice where, a patient's a couple days out and you see some, more anterior chamber cells than you'd like. You got to dilate that patient. You got to check. You got to dilate. You got to check for vitreous cells because you don't know. And if you're not sure, and you see this patient in the morning, and you said, it just looks like maybe some extra inflammation, breakthrough. You're thinking about it. Put them on a steroid every hour. Put them on topical Vigamox every hour. And if you saw that person at 8 a.m., see them back at 4 in the afternoon. If it's worse, it's not breakthrough inflammation. It's endophthalmitis. They need to tap and inject immediately.
That's a great point.
It's
don't always wait
worse.
till the next day. Like if something's really hot.
Yeah,
You're
it's
getting
gonna progress and exponentially get worse. Yeah, check them back later today.
Usually hypopians will have a flat top, and sometimes a little reflux of trimoxy. It's going to be layered like an anthill, and it'll be a quiet, chill eye. There's some layered trimoxy sitting at the bottom of a partial vitreous separation. The top of the vitreous is separated, the bottom's not, so it just layers at the interface.
You turn that upside down, it kind of looks like the state of Kentucky, doesn't it?
It maybe does. Oh, we got a blaze because we're late. So we're trying to make this end at 1. If it's 10:10, then we took exactly 3 hours.
I thought we were going until midnight.
Oh, yes, you guys are the ones that wanted to go until 12 or 1.
Yeah, they're all ready to just tug on through.
We got time. A lot of this stuff here on loose zonules we already talked about. So, just the one thing about the follow-up, though, is if we have a capsular tension ring in the bag, sometimes they could try to decenter later in life. And if you catch it early, we can just add a stitch at that point to lasso it and link it to the wall of the eye, like that one real fun surgery. But nowadays, I don't even do the tunnels. I just take 1 stitch, 2 stitch, burn the flanges, and it's actually faster and neater. But those aren't that common. Never cut the white or the blue stitches. Refractive surprise, we drilled it into your head. So we don't need to say any of these things because we've already told you all of these things. So we'll just click the buttons on this one. We cheat the opposite direction on the second eye. Don't ever say you put in the wrong lens. They'll hate us and they'll not trust you, but just, your eye shifted during the healing process. Or we always put in the lens that all the data points to, your eye is less predictable. But, if you tell them that it's just kind of a shift in the healing, I feel sorry I shifted.
Yeah, I tell them you didn't heal up as the formula said you should.
If they're 20 happy, like 2025, don't make them unhappy. Say, oh, your toric lens is supposed to be here, but it's here. Remember, some of the power of the cornea is hidden, and that's why we get refractive surprise. They come out 2020, 2025, and you think the toric lens is supposed to be like 40 degrees different. Well, it's never going to be off that much. But if you think it's supposed to be somewhere else, like, wait, the refraction's almost nothing, they're done. Because sometimes we find that some of the hidden cornea power is like a black box, but when the case is done, now that mystery is solved, and maybe it actually was supposed to be the true power is where it actually is, and that's why the refraction is nothing. And we actually have ways of calculating that. If they had a larger refraction, they're like 2040, and we're like, I don't like that. Then we plug in the post-op data to kind of solve for the hidden power of the cornea, and then it'll tell us the true best position is maybe right where you intended it. But it actually might be, oh no, it actually would be best right here. And it was, oh, I got to move that. So it's only want to do something if there's a significant refractive error. Okay, temporal shadows. Some people have peripheral vision that goes out so far they can see the edge of the lens. And they're not just seeing the shadow from the edge of the lens, a crescent. They're actually seeing shadow, then the light that goes beyond the shadow. And it's distracting. I got this weird flash. You're seeing the shadow and the light that goes beyond, because their peripheral vision goes so far out that some of it goes beyond the shadow. The edge of the lens casts a shadow. Now, I really think this is excellent peripheral vision. I see a few of these a year, but almost all the patients you check, look straight ahead. Can you see my fingers here? 2, 1. A lot of people stop right here. They're going to get, you're going to get behind the plane of their eyebrow. And they're going to say, 2. And I always say, were you a teacher? But you just make them aware that you have uniquely good peripheral vision. And then all of a sudden they're proud of that. So they come in, and then you'll know if it's really bothering them. Like, oh, okay, give it time. A lot of people do get better over time. There is one trick we can do that actually Ian researched and found. Brilliant surgeon at Cincinnati Eye Institute, Michael Snyder. He'll take the optic, which is in the bag, he'll loosen things and prolapse the optic out of the bag. The arms are still in it, but that tiny forward movement of the lens sometimes makes it harder for the light to reach the edge of the lens to cast the shadow, and the symptoms will get better 50 to 80% in terms of intensity. But you can't make it go away all the time. It's like that's the way your retina is. Like you have peripheral vision that goes way the heck out there. You're seeing the edge of your lens. Start making them proud of it. That wow, you got amazing peripheral vision. And if it still persists, sometimes we can help it. Okay, posterior capsule opacities. Like you can't always polish away everything that's on the capsule, because if it's real weak, wrinkly, redundant capsule, trying to polish it might make it break, bunch up, and tear. Posterior polar cataract, it might not be a normal capsule. You're going to break it if you polish it. Sometimes, if a little rent starts during polishing, we're just going to stop and say that we're going to yag that later. Sometimes it's actually fibrosis. It's not lens material. It's fibrosis. That stuff is one with the capsule, and that's an example of it. You are not polishing that off. You try to peel it off, you're going to peel a hole in the capsule. So you just can't remove it. And sometimes there's a wrinkle in the capsule. Now that won't cause just a block of the vision, but what can a wrinkle in the capsule do, Ian, this redundant capsule? What will that do to the vision?
Oh man, all you optics people know this. What do vertical streaks cause?
It acts like a little mini cylinder. So you will get
Little Maddox rod effect, a horizontal line that person's going to see.
Yep, perpendicular to the streak. You see little streaks off the headlights. Like, oh my God. But it's amazing because you'll look in there and you'll look where the folds are. Folds are right here. And you'll say, oh, are you seeing streaks off of headlights right here? Yes. How'd you know that? And all of these entities, the treatment is, well, see if it goes away when the capsule shrink wraps. Maybe the folds go away. But all these things, that's what YAG is for. You just YAG it. And once the capsule's stable and shrink wrapped, you get paid for it. Don't YAG it. Remember, if you think you might need a lens exchange, oh, you're multifocal intolerant, you have trace capsule opacity. No, it's going to make it harder to do an exchange. Posterior capsule openings. Sometimes you have bad technique. Maybe it's the patient moving. Maybe it was pre-existing posterior polar. Maybe it's actually a zonular opening, and that's why the vitreous is coming around. But there's all kinds of reasons to have a capsule opening. But the risks that it poses, it can make you at risk for a retina detachment, the sequelae, I should say. If a vitreous strand comes to the wound, that's an infection risk. CME risk. You can have a posterior fragment fall to the back. It might be hard to support the new lens. Lens could fall to the back. Pressure spike, all this viscoat that you're trying to tamponade the vitreous with. But this is an example of a vitreous strand. Now, an easy way to treat that is to shoot it with a laser. Now, we hardly ever see these. So our poor ODs don't get a lot of experience in yagging vitreous strands. I think that's the only picture we have of one. So you could yag that, and that will break the traction. This is a 3-piece lens designed to live in the sulcus, but you need to press it backwards so that it locks on the capsular rhexis. And sometimes there's a hole in the capsule, but part of it's still intact. What if that opacifies? Probably want your surgeon's practice to do that YAG, because in this scenario, the rhexis has been stretched to a cat eye, and you can see that little cat eye vertically stretched rhexis. And what is it stretched around? So the optics behind the rhexis, the little haptics are like tent posts in front of the rhexis. So that little loop of the rhexis is stretched around the little tent posts at 12 and 6 o'clock. If you YAG that part, there's nothing supporting the lens anymore. It's not a button in a buttonhole. You just tore open the buttonhole, lens can decenter. So, yeah, if there's cloudiness on the bag, you can not YAG this part. That's part of the cat eye. But you could YAG somewhere on the back if you had to. But probably let the surgeons do that. It's a little later than I thought. I'm sorry about that. We weren't supposed to go to sleep. Got too much material. I got to trim it down. Questions,
No, we
anybody?
got started about 15 minutes late, so we're right.
Okay,
right
so
around
we're close. Okay, but yeah, sorry to start late. The technical difficulties. Well, no questions. Just if you feel free to take a screenshot or jot down our cell phones. Certainly, if you guys are going to practice in the area, Ian McWhirter and I are likely to be in the area long term, wherever we end up. And hey, right now we're with the great Bennett and Bloom practice. So I'm going to hit this button, and that's it. I hope you guys enjoyed it. We'll have fun again in a few weeks. Call with any questions. Call anytime.